Well, Mike, thank you for that kind introduction, and also to Lowell for inviting me here. I'm really excited to be here. I'm especially excited to be invited to an anthropology lecture series when I'm not an anthropologist. So that's really very kind of you to include me in my work. I'd like to talk about global health, justice, and governance. The work I'm going to present to you is part of a broader project that's culminating in a book that I'm going to be publishing with Oxford University Press. So just by way of outline, I'm going to share with you some empirical work on health disparities among countries and indicators that are associated with health inequalities among countries. Then I'll mention some different frameworks for health equity that we might think about and a sense of responsibility for these kinds of inequalities to the extent that there is a overarching obligation or sense of responsibility. Why governance matters, why justice matters, and then duties and responsibilities related to global and state roles for these kinds of inequalities and differences in health across the world. So first, let me present some macro level data. So this is not the micro level, this is the macro level. And the first, this is an analysis that was conducted with data from the World Development Indicators, which is the World Bank's international data set of different countries that are members of the World Bank group, and different social, economic, and other kinds of indicators, health-related indicators, for example. And we conducted a k-means clustering technique to try to understand groups of countries with respect to their health status. And we looked at a few different health indicators. The first was under 5 mortality. And basically what we were interested in is trying to understand inequality in health from the perspective of how different groups of countries compare to other groups along the spectrum. So we found that there was 3 different sort of core groups of countries that were along this spectrum of the global distribution of health for under 5 mortality. So if you look at the picture here, we see that the dark green color is the better off group of countries. And those countries have under 5 mortality rates of about 16 per 1,000 live births on average. And we see that the range is from about 14 to 18. And this, as you can see, most developed countries are in this dark green category. And then there's sort of a middle category, and then the light green is the lower health countries. And these countries have under 5 mortality rates of about 160 per 1,000 live births. So, and the range is about 153 to 177. So 16% of people born in those countries die before the age of 5. And so what we see here is a distribution of poor health outcomes in terms of under 5 mortality in the, as you can tell, the African and sub-Saharan African region. So we have a strong geographic distribution of health. And can anybody tell me what this country up here is in the light green? Nope. Afghanistan, yeah. And so what we see up there is the very light green is Afghanistan. So that's a little bit of an outlier in that region, although the other countries nearby are in the middle group in terms of health. But for the most part, we see a high distribution of poor health in the African continent. This next set of analysis that we did the same k-means clustering technique. And this data is on adult male mortality. And this is dying prematurely, which is dying before the age of 65. And we found 3 different groups again in this data, and the dark blue is the better off health countries. Those countries have adult male mortality rates of about 126 per 1,000 male adults. And again, this is premature mortality before age 65. And the light blue is the worst off countries, and we see an average of about 427 deaths per 1,000 male adults. So about half of the population in those countries is dying before age 65. That's adults. And again, we see a very strong concentration of the poor health countries in Africa, and in particular here in the southern part of Africa. This is just to give you a picture of where, what the distribution of health looks like in the world. And then this last set of analyses that we did was with female mortality. And we again had 3 groups of countries. The maroon colored countries are the better off countries in terms of health. So they have lower mortality rates of about 81 per 1,000 female adults dies prematurely. And the yellow group of countries is the worst off countries, and those countries have about 428 deaths per 1,000 female adults. And so again, about almost half the population is dying prematurely. And again, you see a very strong concentration of those countries in the southern African nations. So what we see from this picture is a distribution of health across the world in which there's strong concentrations of poor health, particularly in certain parts of the world, and particularly in Africa. And we see better off countries distributed primarily among the for the most part, the better off or well off countries. So we wanted to also look at how things have changed over time, because what we're interested in terms of inequalities is not just inequality per se, but how the gap between the better off countries and the worse off countries may be changing over time. Is it getting smaller? Is it getting larger? Is there a significant difference? And so we were able to, with this data from the World Bank, look over several decades of data from 1960 on, and we're actually currently updating this analysis through 2009. And the under 5 mortality among the worse off group is the orange line, and the better off group is the blue dotted line with the squares. And so basically what we're looking for here is this trend over time. We know that there's a gap from the previous analysis. We knew there was a gap between better off and worse off countries. And what we're interested in here is whether the gap has been decreasing or increasing or staying the same over time. And what we see is essentially that the gap is between the worst off, which is the orange line, and the better off, which is the blue line with the squares, has essentially been about the same. There was a narrowing of the gap for a certain period of time between 1980 and 1990. Still downward slope, but the gap is still really there. And the question is why and what's associated with that. And we'll talk about that in a minute. This is the data over time for male mortality. And what we see here is the orange line, again, is those worst off countries in Africa. The blue dotted line with the squares is the better off countries. And we see over time there was somewhat of a reduction in the gap between these sets of countries from 1960 to 1990, then a bit of an increase, and then a leveling off between in that last decade. And then this is the data on the female mortality, and we published these results in a peer-reviewed journal, and this was actually one of the leading sort of issues with this, is that actually we did this analysis after and found out that this trend in female mortality was really quite an interesting story. Here we see, again, the orange line is the countries that are worse off in terms of the female mortality. The blue line is the better off countries. And what we see is there is a big gap, and the gap was being reduced to a certain extent the first several decades. And then what we see from 1990 on is actually an uptick and an increase in the gap. We're not only seeing not a closing of the gap, we're also seeing actually an increase in the gap. So we think that this is concerning from an ethical perspective or moral perspective. And then this just lastly, in terms of data to give you a picture of what's been going on, here is the rate of change of the mortality reduction. And so this is what's helping us understand why or why not why that gap is or is not closing. The group, the better off group is the blue bar, and the worse off group is the green bar here, and this is the rate of change in the under 5 mortality. Basically, you want to see a higher rate of change, so you want to see higher numbers, and you see that in the blue graphs. So the better off countries are just doing a better job at reducing their under 5 mortality. They're doing it more efficiently, whereas the worse off countries are not only reducing the mortality at a less effective rate, but there's variation in that rate as well. And so in order to try to close the gap, we need to address the rate of change in the mortality reduction. Here's similar data for the adult male mortality. And here, again, the blue bars are the better off countries, those countries that were doing better in terms of their health outcomes. The green bars are the countries that were not doing as well. And what we see again is the rate of change in the reduction in mortality here, adult male mortality, is just better in the better off countries. And then the reversal that we see from 1990 to 2000 is not only is it not reduction, the rate of change is not going in the right direction, meaning you're reducing the mortality, that mortality is actually being increased in those countries. And then lastly, here's the adult female mortality. And again, this is very concerning, we think, from an ethical perspective, because the blue bars, again, are the better off countries, the green bars are the worse off countries. And we see, while we see a less of a distance or difference between the rate of change in adult female mortality for the first several decades, we see a very strong difference in the rate of change in the last several decades. So we see a rapid increase in mortality as opposed to a rapid decrease in mortality. A big difference between the better off countries and the worse off. And actually the middle group is doing much better in these last 2 decades. So this is the picture that we're looking at from a global perspective. Okay, so what's going on here, or what's associated with it? Now this is, the analysis that we did was to look at basically risk factors or indicators that were associated with being in the worst off group of countries. So these are these countries that are highly concentrated and have those very poor health outcomes. And what we found was there are several social and economic factors that are related. We don't know causality. We did not tease out causality. We know that they're related. And what we know is extreme poverty is a risk factor for being in a country being in that worse off health group. So in the worse health countries, a percentage of the population that lives on less than $1 a day, which is an international measure of extreme poverty, is about 50%. So half of the people that live in those countries live on less than $1 a day. It's a large proportion. So it's not just a small chunk of people. It's a large, almost a majority of the population is living in extreme poverty. Those countries also experience inflation and currency instability, which makes it very difficult. It's volatility and makes it difficult to exchange and be in the international economic environment. They have a lower percentage of GDP in trade, which means they're less connected to the global economy. They have a higher percentage of the population living in rural areas, which means that they have less access to a lot of the resources that we find in urban settings or semi-urban settings. They have poor communication information technology, and of course in this day and age, people are completely left behind if they're not connected through information technology, and they have much higher rates of female illiteracy. And in fact, the majority of females in those countries are illiterate. So these are risk factors. These are indicators that are associated with being in the worst health outcome countries. And then there's this is the last set of data that I'm going to show you. The other factors that are associated with these health inequalities relate to the public health and healthcare infrastructure. And these are not perfect measures. We know that these kinds of measures, which are, there's lots of caveats related to the way this data is defined and collected, but they do give some indication of what the infrastructure looks like. And so in the poor health countries, in that lower group of countries, there's less spending on healthcare, and by a large amount. So on average, about $10 per person is spent on healthcare, and these are purchasing power parity dollars. So these are comparing a dollar in one country with a dollar in another country, so you can get a good sense of that. There's lower per capita outpatient visits. That just means that there's less utilization of outpatient facilities in those countries by a large margin. There's lower per capita hospital beds. I mean, not that, of course, there can be too many beds in many settings, but if there's not enough hospital beds, there's really not the capacity there. I mean, we saw this very clearly, for example, with the Ebola crisis in those Western African countries. And then there's lower physicians and nurses per capita. Again, this is just a measure of the human resources that are available to the population. And we're talking about a tenfold and significant difference in these kinds of measures. There's also much lower rates of immunization and lower rates of access to improved water, that's basic sanitation, and then lower rates of access to sanitation in terms of plumbing and these kinds of measures. So the whole sort of, this gives a sense of sort of the macro social and economic indicators that put countries at risk for being in the worst health group. There's again, this is not causal though, this is associative. So it could be bidirectional, of course, these relationships. Okay, so the next question is, who cares? Not everybody cares. Not everybody cares. So often I speak to audiences where it's preaching to the choir and everybody is on board with the notion that there's something troubling or problematic about these kinds of differences and these kinds of associations globally. But that's, is not necessarily a unanimous or view, or there's not necessarily a consensus about that. Why? Because there's different paradigms and there's different perspectives that one can use or employ to look at these kinds of data. And the first is a neoliberal perspective, and in that case, basically the focus of what we're interested in is income, wealth, GDP, and to the extent that a country is growing economically or there are certain gains in GDP, then we may not be concerned about whether or not there are also inequalities in health as a result. It really isn't that important. As long as the country's growing, as long as income is improving, that's what really matters. And if health inequalities exist, then so be it. Another area is utilitarianism, or happiness or pleasure, and as long as people are happy and we think that they have high utility, then if they have poor health outcomes, then that's not a problem. And there's nothing that concerns us about these kind of massive differences in health. There's a libertarian perspective that talks about negative rights or putting procedural justice or political and civil rights and infrastructure in place, and as long as countries are democratic or they have on the books, certain rights, then and there are many countries that have these kinds of infrastructures in place that also have significant inequalities in health or have health disparities within their countries and vis-a-vis the rest of the world. So if we're looking at that, this sort of gets into the tension between civil and political rights and what we call positive rights or rights to health and other social and economic areas of life. Then there's another framework that suggests that as long as we provide certain basic goods for people, then the outcomes of whatever results from that is acceptable from a normative perspective. And so, if there's transfers in wealth across the world, and there's certain countries that are putting in place basic packages for people, whether or not they're implemented is a question, but then the outcomes that flow from that, the health outcomes that flow from that, really aren't a matter of our inquiry or concern. And then there's a more cosmopolitan perspective, which suggests that there are moral duties and obligations of all citizens across the world, and that those kinds of differences in health are concerning because people have dignity, people have rights, and we also maybe wealthier countries may be responsible in some way for the deleterious economic situation, either through colonialism or certain trade practices or other kinds of global rules that may have resulted in poor economic conditions that have resulted in poor health outcomes. Then we may be responsible, or there may be moral obligation to do something about those inequalities. That's sort of the line of argument or line of thinking. It's called a duty of rectification, to rectify a bad situation that happened as a result of our actions or inactions. And usually the rectification comes in the form of foreign aid or assistance to those countries. And then there's this sort of these are simplified categories, but there's another set of folks who are thinking about this in terms of human flourishing and human lives. That's the sort of family of work that I'm sort of a part of, and this area looks at the human as an entity and suggests that anywhere, on any place in the world, if someone's health is threatened in some way, or people have fewer opportunities to be healthy than other parts of the world, then we have an obligation to rectify that situation, or to try to help set up systems and measures to prevent those gaps from occurring in the first place. I'll talk a little bit more about what that means. And that basically takes human flourishing, that people's ability to flourish wherever they are, humans, is of concern to us ethically and morally. And by virtue of people's humanity and the fact that they're living human lives. That matters, and if their health is threatened or is in any way lessened, then we have a duty to address that. So what does that mean more specifically in terms of health equity and moral responsibility? What it means is that these health inequalities that I just showed you, I spent so much time showing you what they look like, how we've gotten to where they are, whether they've changed or not, what's associated with them. Those inequalities represent failures in the global system and the domestic system to discharge duties and obligations for global health equity. And I'll talk a little bit more about what that means. So This line of thinking suggests that human flourishing and health are morally central aims that are shared by all persons by virtue of their humanity. So that's what's really, really important. Being human itself, our common humanity, confers a moral status on all of us, no matter where anybody lives on this planet. And that this kind of thinking or this kind of objective is actually the proper or the right or the normatively more appealing end of social and political activity, both domestically and globally. That's a very short way of putting together the sort of basic end. Health is morally salient as a human characteristic, and thus then warrants respect and requires protection and promotion. That's the sort of preventing those health inequalities, and then rectifying those inequalities once they present themselves. And we need to meet people's health needs and prevent risks to their health in order for them to flourish. And health inequalities then can be reduced through social organization and collective action at the global and the domestic level. Why and how do we know that? We know that because what I just showed you was a difference in a number of countries that have achieved a higher level status and those that haven't. So if it wasn't possible, we wouldn't see the difference. So that's why I go through the whole spiel of showing you the inequalities in the first place, and showing you differences in one group of countries and another group of countries. So actually, there are three, but I wanted to highlight the differences with the first group and the last group. Why? Because if the first group can achieve certain levels of health, and they do that, and we assume that there's no biological distribution that's concentrated in those countries, so all those maroon countries and dark blue and dark green countries, if there's nothing special about the biology of the people there, then the reason those people in those countries have higher health status is because of social organization and collective action. And so why is it, so it's morally arbitrary, or there's nothing that separates, being born, it's just unlucky if you get born in one of the bright blue or the yellow or the bright green country versus in those other countries. Okay, so that's why then reform of the global and domestic health governance is required, because it's possible, and the inequities are a motivation for acting responsibly and dutifully towards our fellow humans. That's the sort of thinking. Okay, so tackling health inequalities then reflects broader social, political, economic environments in which people live. We know from social scientific research that these kinds of inequalities won't be reduced through market mechanisms alone, that we need government and public policy. We also know that they're not reduced just by the health sector. Those statements are based on social scientific research that we have accumulated over decades. And the international and national responses to health inequalities are rooted in ethical values about health. And those values are important to be informed by the principle of treating all people equally in morally relevant ways, and respecting all people by respecting their health and their human flourishing. So this notion of shared health governance that I've been working on, which is a form or a framework of global health governance, focuses on global health equity as informed by these kinds of principles, as opposed to what I call a rational actor model, which is based on self and national interest alone. That we need an ethical framework to motivate and to provide guidance for the reform of the global and domestic system to rectify and to try to more equalize those inequalities in health. Okay? So the reason that justice matters is, number one, we need an ethical framework to motivate and to provide guidance and to provide an overall objective for what we're after, which I've just set forth in very basic terms. And also because reducing the health disparities requires social organization in these basic categories. So resources, related legislation and public policy, public regulation, oversight, and the creation of public goods. In all these areas, all four, an ethical value of health, the value that health is important and health for everyone is important, is required in these policy domains. So health and global governance should then place the individual health and the human flourishing at the center of health governance. And that's what's really the center of the shared health governance and provincial globalism frameworks. Okay, so then we talk about what it means to go through these different policy areas and what it means to redistribute resources, and how this might be a sort of a plan or an approach to reducing these inequalities. Well, we redistribute resources between different groups of people, the wealthy and the poor, the well to the sick. That's the basis of health insurance, is redistributing resources from the well, even an individual person when one's well to when one becomes sick, and across the population from the well to the sick. And then, of course, through the age span. From the middle age, which is the productive age in the human lifespan, and to the elderly and the young, which are the less productive ages. Although these days I see great productivity among the elderly and the young, but for the most part that's really what we've seen demographically over time. And these are the policy measures that we use for equity, to promote equity. We use progressive taxation, which is this redistribution of the wealthy to the poor. We use equitable and efficient risk pooling, which is basically what insurance is all about, and health insurance in particular, and public health, creating public health programs across the population. We use economies of scale, redistribute expenditure patterns, and we subsidize and provide cash transfers. So this is sort of the toolkit that we have. But that's for equity. This is the toolkit for equity. And so in particular, we also have different sectorial policies. In terms of legislation and policy, we have the financing and health insurance. That is a major component of a plan, global and domestic policy to reduce health inequalities. Why? Because we have social scientific evidence that makes very clear that the failure to have health insurance, not just payment for health care, but health insurance, puts people at risk in terms of their health, being able to protect their health, to prevent health risks from occurring, to prevent illnesses, and also the treatment of illnesses once they occur. And also the lack of health insurance has deleterious financial effects on people and their lives, themselves individually, their households, and that in turn also has deleterious effects on their health. So it's a vicious cycle, and the virtuous cycle for health equity is insurance, health insurance, not out-of-pocket expenditures, just paying on a time-by-time basis. We have lots of social scientific evidence that demonstrates that. And we also have years of data from countries that have chosen over time to expand health equity to their populations through national health insurance systems. Now, we have a lot of different kinds of systems. The ones in Europe are different from the ones in Asia, and there are lots of different kinds of ways in which countries go about expanding health insurance to their populations universally, and our country was one of the last to do that. But we have lots of very good, very nice case studies of how this occurs. The public provision of health services where the market fails to deliver, we also have very good social scientific evidence on that, because the free market doesn't exist in healthcare and public health because there are so many market failures. So these are the prongs, the policy prongs to health equity, not the free market. The provision of public health information, surveillance and services as well. Okay, and then there's the other policy sectors. I won't go into that, but this is generally the idea that there are other policy sectors that affect health equity, reducing inequalities in health, and those are part of the broader approach as well. Public regulation and oversight of private markets. So this, private markets can be a part of the whole framework. They just can't be on their own. They need to be regulated in terms of goals of health equity. So these are the different ways in which we regulate the healthcare and public health sector, and then other policy sectors as well. And so the duties and responsibilities, more particularly of global and state roles, are that state actors and institutions assume the primary responsibility. So you look at that picture of the world, all that different data that I showed you, and you think, well, who's responsible? If there's a moral responsibility, if there's an ethical aim and objectives, and you're convinced that what I've told you makes sense, then who is responsible? And the primary responsibility, creating social conditions in countries for fulfilling all individuals' opportunity to be healthy, falls on the state. And the state is in the position to reduce the shortfall between the potential and actual health within the nation. However, from a provincial globalism perspective, the provincial consensus has to accompany the global consensus. Otherwise, global actors aren't going to be operating in the same way across different countries. And we'll continue to see stark inequalities in health instead of seeing a more closer alignment of health across the world. Okay? So we want to reduce that variation. We want to have more consensus. And then in order to have more consensus, we need to have a consensus across countries, and we need to have a consensus with countries, within countries, with the global community. Because the global community sets the rules of the game. So duties and responsibilities for the global community then is to support and facilitate the domestic communities in terms of creating conditions in which societies can develop and flourish to promote the health of their populations. This is a broad-based approach addressing all the determinants of health, and this involves creating a level playing field across the globe. And there's lots of research that's being done and analysis now of the global rules of the game and how they're skewed in some way towards certain players and certain countries. And the asymmetries in power and influence in the global rules of the game, whether it be the health, the trade, the economic system, that skew the global environment, that then has a resultant effect on the skew in the health outcomes. And so what we want to do is remedy these global inequalities and affluence, power, and social, political, and economic opportunities so that when the global framework can be supportive and facilitate equity at the domestic level, by doing so in a way that's informed by health equity, as opposed to what? As opposed to being informed by particular interests of particular actors, which may not be aligned with equity and health. May have very different motivations. So state actors and institutions assume the primary responsibility. They take efforts to reduce the shortfall. Global responsibilities, here's the macro social environment. I'm not going to go through that. And let me talk particularly about global institutions, health institutions. What can they do? So how can the global infrastructure and the global rules of the game and global policy be more health equity promoting? Well, one thing is knowledge and information. There's a huge knowledge gap and information gap across the globe, and that makes a difference. Empowering individuals and groups is an important measure. Technical assistance and financial aid is very important, in particular focusing on health systems and the infrastructure at the domestic level, and then more coordination across the global system. And these are different examples of those areas. So what do we mean by generating, disseminating knowledge and information? We mean creating new technologies. We mean disseminating existing knowledge. We mean managing knowledge and information, and then helping countries themselves develop the infrastructure and research capacity. We see this in virtually every major disease epidemic or pandemic. We see problems with information, the flow of information at the domestic level. We saw that in SARS. We saw it in the Ebola epidemic. We see this across the board in terms of these particular outbreaks. And this is the more the empowerment. And then we have I'm almost done with my slides. And I want to end by focusing particularly on the health systems development. This is in a real contrast to much of the work that's being done in global health assistance, which is focused on what we call vertical programs or specific diseases. So there's lots of money just for AIDS, or lots of money just for malaria, or lots of money just for TB, or different particular diseases. Whereas this approach is really much more of a health systems approach. That really what's required for health equity is to set up equitable and efficient health financing and insurance systems, human resources, so the system has the capacity, the different facilities, regulatory agencies at the country level, and so that the countries themselves can. We saw this with the West African countries with the Ebola epidemic. The health system was not sufficient to address the epidemic. The public health system wasn't in terms of information, surveillance, and understanding and tracing the disease. We saw that the CDC came in and was helping the countries understand and trace the disease and contain it. The health system was not in place in terms of facilities, human resources, doctors, nurses, equipment, just wasn't there. So nobody died from Ebola in the United States. Why? Because we were able to trace people, contain the disease, we were able to treat it, provide the care that was needed. So, and you didn't need a country that had as expensive a healthcare system as the United States to do that. But you need a country, you need a society that has a health system that's sufficient to address these diseases that present. Because we don't know when the next, we have Zika, we don't know when the next one's going to come. And so we need to be prepared. This is a part of it, all being prepared. The financial assistance for it, and then of course global advocacy to create a motivation and make clear what the necessary steps are. 2 more slides. So more on the state's obligations is creating an institutional framework for the health sector. This is all what at the country level and the subnational level, which is sometimes the state or the provincial, what we call provinces, but that's what I mean by provincial in this case. This is setting up the infrastructure, the regulatory environment, the training of personnel, this human resources, the facilities, and then the knowledge and information, which is the big public health piece. It's basically what our CDC does, and our state and local public health departments. And that's the same in other countries too. It's just a different unit of analysis. Again, the health insurance system, equitable and affordable, and then here's the actual delivery of the care, equal access to quality goods and services, and this is ensuring necessary health care and public health to everyone, and also the sort of more proximal determinants of health as well. Okay, so this is my last slide. Basically, what I've been talking about is health inequalities and the need to respond to them from a normative perspective. That these international and national responses to these inequalities really need to be rooted or based in this core ethical value about health and the distribution of health. And that these ethical principles create standards then and have the power to motivate, to shape global and national obligations, and then hold actors accountable for those through these policy measures that are set up and put in place and are derived from these health equity goals and principles. And that without this sort of ethical framework to alter things in that direction on this path that can hopefully reduce these big gaps, that business as usual. So things will just keep on, there's a path dependency, just keep on going the way that they're going. That will prevail, and as we saw, that's why I showed you the distribution of health inequalities over time, those gaps are not going to be reduced. And this is sort of a plan and an approach to doing that. So that's all I have to say. Okay, yes?
Yeah, I just have a question. I know, as you said, Ebola, excuse me,
Yeah.
was, it's not, people don't die of it here, and yet they died of it in Africa.
Yeah.
And is it not really the cost of the drug and the distribution of the drug as well as the information?
Mm-hmm.
And how do we give money to
Mm-hmm.
these countries, or do we I'm not quite sure how it can be reduced, how the deaths there can be reduced, other than, there's so much.
Mm-hmm.
I mean, where do you start?
Mm-hmm.
I guess that's kind of my question.
Mm-hmm. Mm-hmm.
Do you start with education? Do you start? It seems overwhelming.
Yeah, yeah, it does, and that's why I was trying to break it down, because you start with the health system. You start with the health system, and we have very nice social scientific research from decades of work that's been done to demonstrate that, and we have lots of different models, so it's not like a blueprint or one size fits all. There's lots of different approaches to providing universal health insurance and universal care across the population, and universal public health across the population. And that's where you start. And we also know that there's a lot of variation in terms of the cost and quality of how you do that. And so you're talking about the cost, which is absolutely essential to bring up. So it's a great question, and it's a good problem to be focusing on, because yes, it is costly, and of course everything's more costly in America than it is anywhere else, because we have a system that is not efficient. But in Europe, and in East Asia, for example, I do a lot of work in South Korea that had a health system that looked a lot like the American system before they became a national health insurance system and a national healthcare system. And they are not a perfect system. No, there is no perfect system, by the way. But they have expanded insurance and healthcare to the population in a much more cost-effective way than some other places, and certainly what we're doing now here. Some of the European countries, some countries are more cost-effective than others, but for the most part, many of them have expanded. So the health system is the place to start. And things get costly, even more costly, actually, when the health system isn't in place. Why? Because the basic infrastructure to support what may be actually an incremental. So the Ebola situation, that was not a hugely costly condition, actually, to care for in the United States. The drugs were actually minimal to it. It really was the supportive care for people and the public health measures to trace people and make sure it didn't contain it so that it didn't spread. Right. And that's all public health, and that's all public health infrastructure. And it's not just the CDC. The CDC is a national organization that oversees the state and the local levels. So having those infrastructure, so the big investments are the infrastructure. And so when you say what do you do too internationally is you support the infrastructure.
So So
Yeah.
you can basically, but can you pick up an infrastructure and put it in a country that doesn't have an infrastructure like some of the bright green ones?
It's a very good question. Yes, you can. Yes, you can. We have very good examples. You know, what you do, what has evolved naturally in terms of the natural experiments all over the world is countries have developed their own versions. That's why the provincial and the provincial globalism is, it's a consensus, but it's a broad consensus about a bunch of principles that can be implemented very differently in different countries. So a very poor society is Kerala, that has, you know, essentially universal access to health care and funding, and it's very inexpensive to do that there. And Japan is a pretty inexpensive, health system as compared to some of the European or Northern European countries, their health systems. Cuba, I mean, Cuba has there's all sorts of questions about the Cuban society, but its health system is universal, and it's very low cost. It's not a perfect system either, but it has its own variety. And actually the Cubans and Cuban physicians and health professionals were providing assistance in the Ebola crisis. So it can be done. And what's good is that we have lots of natural experiments. It's not like this is pie in the sky making up something. So these are great questions. Yeah.
Yeah, one of the issues about healthcare is much of healthcare is really taking care of the patient. It's not a magic pill. It's not a medication. It's taking care of all of the patient's needs. And just doing a basic nursing care is really, in most cases, well, certainly in Ebola, there was no drug to treat Ebola.
Mm-hmm.
These patients needed supportive care.
Mm-hmm.
And the system in Africa just wasn't there.
No,
for them.
was not there. It was not there. It wasn't there in the public health system to trace and contain. And that is so essential.
Especially
Yeah.
when families were taking their persons dying of Ebola and burying them and then getting Ebola. That doesn't happen here.
And that's part of the information and knowledge.
Yeah.
That's the big gap. And that just information and knowledge, I mean, which is, of course, there are costs to that because you have to generate it and things like that, but just know it would have reduced, many, many cases of Ebola. So, yeah.
I was struck by your diagrams of the inequities and over time. And something went terribly wrong in the 1980s and 1990s. I think it was probably AIDS. I think that's probably the major factor there. Do you agree with that?
Yeah, we have not done, I get that question a lot. We have not done sub-analyses to know what exactly was driving that, but that is a very good hypothesis. Yeah.
That was sort of the start of all that when we didn't know what the heck this was.
Right.
It's a pretty scary time.
Yeah.
Just a comment and a question. My comment was, the opening slides, I was just really struck by all of Central and South America was in the best categories.
Mm-hmm.
I wouldn't have predicted that.
Mm-hmm.
I'm not questioning that. I'm just really struck by that.
Yeah.
Data. My question, maybe you've already answered it with Mike, but what in the world happened to female mortality over the last 20 years? That's the one thing that seemed to really get worse.
Yeah. Yeah, we have not done the sub-analyses on that, and so we don't have the answers on this particular data. There's lots of literature on HIV and AIDS. There's literature on female mortality, around childbirth, which is, the statistics are 99% of female mortality in and around childbirth is in developing countries or the global south. And so, that of course is a major cause. And then just care for women, in general. Looking at the female literacy rates being so high in these countries, and that just more broadly speaking, that the rights and the status of women in economic independence, all sorts of factors may also be influencing that as well. But we have not done the analysis on that. Yeah, it's a good question though. Yeah.
I think another factor that you have to deal with when you're dealing with these
Yeah. Yeah.
You pour money in and it goes into Swiss bank accounts.
Mm-hmm. Mm-hmm.
So I think that's it's really something that stops people from wanting to do anything about this.
Mm-hmm. Mm-hmm.
And the other thing that certainly came up in the course we teach in medical anthropology is that all the NGOs and all these other aid programs, the people kind of who are being taken care of, they kind of think that they're doing it just for their own benefit, and they want to show pictures of little babies who are dying because that way people give money.
Mm-hmm.
And once they show that there's a positive health effect, then people stop giving money.
Yeah. Yeah.
That's another big problem with leveling the playing field.
Yeah. Yeah, yeah, no, there is that sort of a psychological effect, and it also is a bias against prevention. So prevention, of course, is incredibly effective and cost effective, and prevention, so how do you know when prevention works? Well, when something doesn't happen as opposed to addressing something that does. So you only know that when you went wrong as opposed to when you went right, in many instances. So prevention needs a campaign, a good campaign that's going to, attach to people's intuitions. And that's right. And the other thing is emergencies and like catastrophic disasters. So money flows in these, immediate aftermath of these kinds of experiences, and yet the same amount of money put into preventing or putting in the infrastructure to prevent the negative effects. So you can't prevent a natural disaster, but you could certainly put in place systems of warning and also with building and regulation and things like that. All that kind of infrastructure that can at least mitigate the negative effects. There's very little motivation for that kind of investment. Yeah, so it's a big problem.
Lots of problems. Lots of answers. Let's hope that some of them actually come into play.
Yeah, well, health systems and universal health insurance is really starting to get traction. I think this is something that's on the global landscape now.
Do you have any questions from the rest of the audience?
Yes.
What can the individual do? Because a lot of these proposals are kind of from the government's point of
Yes.
view, kind of bigger agencies. What can an individual do, a bureau activity, to kind of help this cause kind of get lower?
It's a great question. I get that question a lot. This is primarily focused on policy and governments and governance. But one of my new roles at Penn is going to be a faculty chair at the Center for Health and High Impact Philanthropy, which is individuals, right, investing their own money in different areas. And what we're really focusing on is trying to understand better what kind of an impact an individual donor or set of donors can have in terms of investing in these kinds of problems. And I think that's the sort of approach, is to use a vehicle like that, or an institution like that, to try to understand where one's dollars can go the farthest, and then align those with your own preferences for because for individual philanthropy, that's your own preference, but along the lines, I think, of being informed by these kinds of ethical principles. Yeah. Yeah, very good.
Could we also potentially have people, churches, groups of students or whatever, doing things in order to help
Yes.
in certain, so that you don't necessarily have to do the big picture if you don't have millions of dollars, but you can certainly do something.
Yes.
Influence it.
Absolutely, and it doesn't even have to be in terms of investing money. I mean, the message that this is possible. The equity orientation has a lot of legs, has a lot of appeal, and it's not just pie in the sky. This is possible. Look what these countries are doing, or these societies are doing, and with, you know, reasonable amounts of money and good governance, as you said. You know, you can't have corruption. You can't have, you know, lots of ways in which the, you know, the project's being undermined by, you know, these kinds of measures. That, you know, groups, advocacy-oriented groups, or groups that are really educated, you know, and spreading these messages can be very, very effective. I mean, we social movements, you know, we've seen policy changes, we've seen community-wide changes in people's attitudes about lots of social issues, and I just see this as another social issue. You know, health equity is just another issue that requires a great deal of articulation, understanding, and then, you know, policy and private measures. You know, we've seen in lots of areas recently, you know, good changes in people's views, and in a very, very short time too. So.